Well, hey, Dr. Mitchell, I want to thank you for joining me here today so that we can talk through this, get a better understanding of what it's like to be a physician and specifically a radiologist and everything. So what I'd like to do is just start by asking you a couple of questions here, if that'd be okay.
Sure.
Awesome. So can you tell us a little bit about your current occupation and the career path you took to get to where you are today?
Yeah, sure. I am a diagnostic radiologist. That's a medical doctor who specializes in diagnostic imaging. So I trained in CAT scan, MRI, X-ray, ultrasound, nuclear medicine, angiography. All those things were what I trained in residency. And at some points in my career, I've done multiple of those subspecialties, sometimes more than others. Currently, I am a radiologist with the VA hospital and spend most of my time doing MRI, CT, ultrasound, and plain films.
And so tell me a little bit too. I mean, how did you in the past decide that medicine was what you were going to do?
Yeah, I don't know. I think, kind of as a small child going to the pediatrician, I kind of thought that they were kind of, wizards. You go in sick and they look at you and you get a medicine, maybe you don't, but they figure out what's going on with you and get you feeling better. And so it's kind of, I respected that profession and thought that those guys, were held high in esteem by me and my parents. So thought that, if I could study hard and I was smart enough, that might be something that I wanted to do. So yeah, I always thought that maybe I would go into become a pediatrician. That was what you knew as a child and growing up. That was kind of the doctor that I had the most exposure to. So, through grade school, high school, even into college when I was on the pre-med track, kind of always thought I would be a pediatrician. But once I started medical school and get exposure to all the different sides, fields of medicine, kind of drawn towards the radiology and the imaging side of things.
And that something then obviously that you decided in medical school as you were deciding on that specialty, right?
Yeah, for sure. I think that's probably the best approach to have. I know that some people are, say, "Oh, I definitely want to be an orthopedic surgeon," or "I for sure want to be a family practitioner." And more often than not, at least the folks who went through medical school with me, the ones who came in certain of what they wanted to do ended up doing something completely different. The ones who came in and said, "Oh, I'm for sure going to be a surgeon," went into a psychiatric residency at the end. So yeah,
Wow.
you really have to kind of get in there. The first 2 years are all just really basic sciences. It's the biochemistry, anatomy, pathology, kind of to give you a good background, good foundation to build off of. And then the last 2 years are pretty much all in the hospitals, all clinical. And so you'll do anywhere from a couple of weeks to a couple of months of a broad array of all the medical specialties, heavy on the internal medicine, heavy on the pediatrics, heavy on surgery, but there's a lot of opportunity to do. I want to do ENT for a month. I want to do orthopedic surgery. I want to do cardiology. You can kind of, especially your last year, you have a pretty blank slate for picking what you want to get a little bit more exposure into. And so, yeah, once you start getting into some of those, you're like, gosh, I never thought I wanted to do psychiatry, but I had a great rotation and a great preceptor when I was on that rotation, and really sparked an interest in me. So, yeah, for me, it was, kind of really every rotation you're on in the hospital, at some point, somebody's getting some kind of imaging on your patient. It's a head CT, a chest X-ray, whatever it is. So you kind of, radiology was kind of always there. You're always checking reports or going down to the department. So doing enough of that, I was like, gosh, these guys seem to be enjoying what they're doing, and they see all the interesting cases that are in the hospital. Maybe that's something that I'm interested in. So yeah, just the exposure to it, I was like, yeah, this seems to be something that I can make a career out of.
Yeah. So which college did you go to and why?
Yeah, I went to Xavier University here in Cincinnati. when I was finishing up high school, didn't even really think that much about college as I was in high school, but all of a sudden it's senior year and you better have some place to go next year.
Right.
So I kind of had it set in my mind that I wanted to stay local, and a lot of good regional schools around here, but wanted something local. I was a little bit more inclined towards a smaller school, and really that was about as much as I had thought that I'd put into it. But my mother had gotten her master's degree at Xavier
Oh,
and really
okay.
enjoyed it there. So she kind of thought it would be a good fit for me, and basically just showed up there for the first day of class. Didn't do a site visit beforehand.
Really?
Just filled
Oh,
out the
wow.
application, got accepted, and went there. And it was a great experience for me.
And so then medical school was where?
University of Cincinnati. So I think I still wanted to stay local by that point. And UC was kind of my top choice just because, didn't really have to move unless I wanted to. All the family and all the friends were here. So I thought that would be a good support staff to have. And I applied early decision for UC. So that was, with early decision, you basically kind of commit to, this is the only place I'm going to apply to, and if they get in, I'm agreeing to go there. So it kind of takes, from my standpoint, I didn't have to fill out dozens of applications, apply every place, have to spend a lot of time and a lot of money traveling to different places. From the schools side of things, they get some, if they accept you, they pretty much know that they've got you. And so it helps them fill out their classes, and they're not kind of 3 days before class starts, trying to get a decision from people who are late on making their decisions. So,
Right. Yeah.
so I applied probably the spring of my senior year at Xavier, and interviewed over the summer. And by September of senior year, I'd been accepted to UC. So
Wow.
made kind of for a nice rest of the year, kind of the pressure was off a little bit, just had to finish up the undergrad work, and they were going to be ready for me the next year.
So from start to finish, from the beginning of your undergrad through the end of medical school and everything, how many years was it?
So 4 years at Xavier,
Okay.
4 years at University of Cincinnati for medical school, then 4 years of radiology residency, and that was also at University of Cincinnati. And then I did a year of fellowship in body imaging and interventional radiology for a year tacked onto the end. So 13 years after
Wow.
high school before, I was on my own, working solo. Now there's actually an extra year stuck in the middle of that. If you want to do radiology, they have you do, between medical school and the start of radiology residency, pretty much everybody has you do a clinical year, an internship year, where you can do internal medicine, you can do family medicine, you can do a surgical internship for a year. The programs don't really care what it is, as long as you're doing something clinical, which is probably a good thing. You're going to get more hands-on exposure for patients. You're going to have more responsibility in taking care of, not carte blanche, but quite a bit of responsibility. And it gives you a chance to kind of, how does medicine work? A little bit more of, how do things work when you want to work somebody up in the hospital? How quickly do the labs come back? How long are you going to have to take care of a person in the hospital for a standard pneumonia admission? And kind of gives you more of a sense of, how to take care of a patient. In radiology, there's really, it's kind of me sitting in a room by myself all day, looking at a lot of different exams and dictating reports out. So I didn't have that experience. For me, I thought it was fine when I was looking at programs. At the time, I specifically looked for programs that didn't make you do that. I kind of wanted to go, I was ready to start radiology at that point, and didn't feel like it was going to be a big help to me. 30 years later, don't know if it would have been a better help, but I think that the folks that I've talked to who have done that, it was a valuable experience to them. So yeah, 14 years if you count that now.
That's quite a commitment, isn't it? I mean,
yes, it
my
sure
goodness,
is.
for anybody who thinks, oh, I'm just going to go and become a doctor, they don't have I mean,
Yeah,
14 years is the real deal.
it really is. And if you're running through, kind of doing it with no gaps in there, kind of running all the way through college and all the way through, you're pretty much in your mid 30s by the time you're finished with all of your training. So that's, for some folks, that's a pretty big commitment too, because you're watching all your friends that you went to high school and college with. They've started careers, they've bought houses and started a family, and you're kind of still slogging through residency, where that's pretty much taking up all your time. So yeah,
Wow,
it's a big time commitment.
no doubt. So, what would you say you love the most about your job?
Yeah, for being an imager, probably the most rewarding thing is being able to use what I know about anatomy, what I know about disease process, and how that relates to what you might see on a CAT scan or an ultrasound. Be able to use all that to help somebody's symptoms get better.
Hmm.
Somebody comes in and they're in the emergency room, and let's do a CAT scan of the abdomen. We think this patient might have appendicitis, and so we do the CAT scan. I look at it, oh, the appendix is normal, but there's a kidney stone that's stuck and causing some obstruction. So, was able to use something that maybe the doctor who had seen the patient, was, they had a couple of things that they were thinking on. I was able to narrow it down to, yep, here's what the problem is. And before we had that technology, they might have said, oh, I'm pretty sure this is an appendicitis. And surgeon goes in and it's a normal appendix. And then,
Hmm.
you kind of have to go from there. So with the advances that have been made from an imaging standpoint, gosh, you get a pretty good, accurate diagnosis, pretty quickly, in a hospital or an emergency room setting. So that's rewarding. It's also rewarding when you find something unexpected that you can make a difference in somebody's life on. They come in for a X-ray of their back for back pain, and you can see on the X-ray that they've got an aneurysm in their aorta that's pretty big and needs something to be done about it soon, because it goes from you had no symptoms to this thing got big enough and started leaking, and you can get pretty sick pretty fast. So
Wow. Yeah.
finding something unexpected, that was clinically asymptomatic, that the other your doctor wasn't thinking of, but you can kind of catch it early before it becomes a problem. When you see, you don't see those kind of cases every day, but and often enough that kind of keeps you interested in it, and makes you feel like, yeah, today I made a difference for somebody.
So, I have to ask too, what do you like the least about your job or even medicine in general?
Yeah, probably the worst thing about my job is kind of the flip side of the best part of it. It's when you look at an exam on somebody and you find something unexpected,
Hmm.
and a bad disease. Somebody who was coming in thought they had gallstones, and you find that they no, it was looks like it was a colon cancer that spread to your bones and your lungs.
Oh,
And
oh
yeah,
yeah.
so they came in thinking that they had one thing that's easily fixed, and you find something that's maybe not going to have a good outcome, or is going to be a long road to get back to recovery. That's kind of the worst thing, is having to do that report, and kind of just thinking in your mind, boy, this person's life's really going to change when they get this report. And also, if you have somebody, who maybe they had a lung cancer, got that removed, and we're doing routine follow-up, and it's been a year or two and everything's been looking great, and then you get that next one and it looks like something, it's back or it's spread. So
Hmm.
those, those are things that I like, that I don't like in a given day. The rest of it, the rest of it are just minor technical things. There's some things that I think could run a little bit better. There's too hard to get a hold of somebody on the phone because they're busy. Those things are just minor inconveniences. That you're going to have little things like that in any job, no matter where you are. So you get
Right.
used to those, and they're just part of it.
So, if you could change anything about your job or career path, what would you change, if anything?
Yeah, I'm very glad that I went into radiology. Sometimes you say, oh gosh, would it have been nice to have been an orthopedic doctor? Would it have been nice to have tried something else? the longer I've gotten into this, the more I'm like, yeah, this was probably the best choice for me, for my personality, for, just kind of like to get in, get a lot of cases done, be efficient. That's a really good thing for me. I have a less direct interaction with patients. The technologist who does the exam, they're the ones who see the patient, get them onto the equipment that they're using, actually, perform the scan, while I'm sitting in an office, somewhere else, waiting for those images to come to me to be evaluated. And I do kind of miss that, not getting to talk to a patient, not getting to interact with them and see how they're doing. But on the other hand, it's probably good. I'm a bit of a talker, and I'd probably get through about a tenth of the amount of work that I can get through in a day if I was talking to everybody. I like to talk to people. And I'd be very inefficient if I was spending any more time with folks than I usually do. So
you wouldn't fit into kind of the expectations of only seeing patients, over certain specified times, right? Or seeing like
that's right. Yeah,
a set number in an hour or whatever.
Absolutely, yeah, and right. All it would take was me to get talking about something, or them to to bring up something unexpected that we end up talking about, and all of a sudden it's an hour later and I'm 4 patients backed up. So yeah, that probably wouldn't be a great fit for me every day. But yeah, being sequestered in a room by myself with a lot of work to take care of, that's I'm goal oriented and I'm task oriented, so that seems to work really well.
Well, and even that's changed through the years, as I remember with you, right? From the old days of having the actual physical X-rays in front of you to now it all being
Absolutely.
all
Yeah,
digital, right?
and that's, when I started training about 30 years ago, it was all film. Everything you had done was on some kind of film, that you hung on a light box and came out of an X-ray jacket. You dictated onto a cassette tape, and at the end of the day, you take that cassette tape and put it for the transcriptionist to pick up. Maybe tomorrow they listen to your dictations and type up the report. Maybe the end of the next day, I'd get a huge stack of reports that I don't even remember dictating these anymore because it was a day and a half ago. Sign off on all those, and then they go to the mail room to be mailed to your doctor. And so, yeah, that when they used to say, "Oh, your doctor's going to get the report in about a week," that was about right. From the time you had that done until that time that hard copy showed up, it was about a week.
Wow.
Now it's completely different. For the last 15 years, I don't know of any hospital that's still using film. Everything's digital. So you come in, you turn on a computer monitor, and there's a work list of all the exams it's being populated, in real time. And you just start at the top and you kind of click on whatever's next. And yeah, and the dictation's much different too. I dictate to another computer right next to me while I'm looking at the exam. My report's there. As soon as I'm finished dictating, there it is for me to proofread.
Wow.
I click a button and it gets emailed to the doctor. So if you're having kind of a routine X-ray, if you come in for an ankle X-ray, there's a good chance that case was already sent to your doctor before you even got out of the parking lot of the hospital.
Oh
It
my
can
gosh,
be,
it's incredible.
yeah. So that's a phenomenal thing from a patient care
Yeah.
standpoint. That's, I never thought that I would, see that day, that 30 years ago, that wasn't even something that I thought might ever happen. But yeah, that has been wonderful. Now it's not been great for me for my activity level, because it just, there's always work to do. So I don't have any reason to get out of my chair all day. At
Wow.
least in the olden days, you'd have to go over to where they were stacking up the film jackets of what you needed to read, go to the file room, pick up a stack of X-ray jackets, bring them back to your office, put them all up, finish those, bring the old ones, drop them off, get a new stack. So every hour or so, I was at least having to get up and walk across the department and getting a little bit of activity. Now, sometimes they'll say, "Oh, it's 2 o'clock. I better go use the bathroom. I haven't been out of this seat once since then." So that's kind of a bad thing of the job. It's kind of made me a little bit less active. The other thing that has done, that it's kind of been a loss as well as, if you were the doctor who ordered a head CT on your patient and you wanted the results, well, in those old days, it might be a couple of days before you got that report, but you really want to know, maybe they're an inpatient, maybe you just promised them you'd call them in a day or so. So you would come down to the X-ray department because that's the only place that one copy of that head CT was, and you check it out of the file room and bring it over to me to look at and say, hey, can you you read this one yesterday, but the report's not out. Let's go over it. And that was good. It was good for me to learn. You'd get a little bit more on the history of the patient. They'd say, oh, he's really having these symptoms. I didn't have enough space to write everything on the order. I just put headaches on there, but I could get a little bit more of a detailed explanation, and I could teach the family practice or the internal medicine doctor who was coming down to look at it. I could show, here's what a normal head CT looks like, or look at this. This is a small old infarct that they had. See, it was unchanged. So it was a good interaction with me getting a little bit more clinical information and them kind of learning about the test and learning what a stroke looks like on a CT, what
Yeah.
sinus disease looks like. And so now they order it, we do it. 2 seconds later, the report shows up for them. They look at it, they read the report and gets them all their answers. But there's not, there's that communication, that kind of feedback between me as the radiologist and them as the clinician that you used to get all day long. You never see them anymore. They can
Wow.
pull up those images on their PC in their office and look at them and look at the report and say, well, yeah, I kind of think I know where that pneumonia is, where they're talking about it. So yeah, that I do miss that also, the interaction with the other doctors.
Wow. Very interesting, huh? That technology has been a blessing, but it's also been a curse thing when it comes to that, because the speed that you can get things finished doesn't allow you to have kind of that interaction like you're talking about.
That's right. And again, I'd rather have it be this way because, boy, it's really streamlined the care,
Mhm.
that dead time of just kind of waiting literally for something to get typed up and mailed to you, where it had already been interpreted days before. It's a wonderful technology, but yeah, you still kind of get wistful for the old days, I think,
Right.
sometimes.
No doubt. Well, I guess the last question I've got in here or on here, because I already know you answered that if you had to do it all over again, you would. It sure sounds like that. But
Yeah.
what final advice would you give to a student who's considering going into both medicine and or radiology specifically as a profession,
Yeah.
in the future? What would you say to them?
Yeah, I'd say for sure, if you're thinking about it, pursue it. Keep thinking about it. If you're at the high school level, for sure, that's a great time to be thinking about it. But even if you get into college and you have to take a biology class, even though you're an English major, and all of a sudden you say, "Oh, this was kind of interesting. Maybe I've got to bend towards this." Kind of pursue it a little bit. In medical school, most of us were biology, chemistry, pre-med, some sort of science major that was geared towards getting you into medical school. But we had history majors, we had English majors in my medical school class, and so that's, even if you kind of get you're like, well, I'm junior year history major. I should finish what I've started here, but I'm kind of interested in going to medical school. Do I need to spend 2 more years taking more science classes? Not necessarily, but you may want to take some electives in it as well. So keep thinking about it. Definitely helps if you like the science. I think it'll pay off for you in the end. But if you're thinking about it, high school or early on in college, volunteer at a hospital,
Mm,
go to a
great
local
advice.
hospital, maybe,
Yeah.
spend some time in the emergency room and see what's going on there, if that's something that you might like. Or you'd say, that might be, not your cup of tea, but do a job shadowing of your physician or a local physician. Just come in for a day and kind of trail around, see what they do, and see if that might be something that you like. And if it is, definitely definitely pursue it. You have to do it because you like your job, you like taking care of people, you like making a difference for people. The you're always going to have a job if you're a physician, even if it's, you say, I tried clinical medicine for a few years. You can do research. You can be a medical director at a corporation.
Mm.
You can work for an insurance company and being a medical director, where you're really, there's no patient care, but you still get to use medical knowledge. So there is that, but yeah, if it you will have a job, you should be able to make, a livable wage, being a physician. If you're just doing it because you think that your next door neighbor's dad's a doctor, and they've always got a brand new car and they're putting a pool in the back, and you say, gosh, that looks like a way to make a lot of money. You can make a lot of money in it, but if you're only going into it because of the financial side of it, you'll end up not being happy in it. You gotta, there's plenty of other ways to make a really good salary that don't involve, the work, the anxiety, and everything else that goes with being a physician. So yeah, if don't have to be the smartest person in the world, but as long as you're willing to work hard and learn, that's kind of what I ask for out of my doctors. So yeah, if you've got an interest, volunteer, job shadow, take the classes, make sure that you like it. Once you get into medical school, they want to get you through medical school. They're not interested in somebody who comes in and then drops out after a year, because it's very difficult to fill for a third year medical student,
Oh,
or
I bet.
second year medical
Yeah.
student. So once you're in there, they kind of want to get you through. So the getting in's kind of the hard part, and you're going to have to work hard. But yeah, once you get in there, even if you say, I think I want to be a doctor, but I don't know which type, you'll get so much exposure to all the different areas in medicine. You'll find something that if you wanted to go into it, you're going to find something that'll be a niche for you there. And yeah, and from there, if you decide to go into radiology, boy, it's there's no shortage of jobs for radiologists. It's in demand. I don't think it's going away anytime soon. They sometimes they'll say, oh, we're doing too many CAT scans, we're doing too many MRIs, we need to cut back on that. But when it's you or your family member, you want them to have that CAT scan, you
Right.
want them to have the MRI. So the numbers just keep going up. So there's definitely a need for good radiologists out there. There's also some talk that with the computers and the artificial intelligence advancing so much, that maybe we won't need human radiologists anymore. We'll have all robot computers make, you feed the images through a computer and it tells you, oh, this is pneumonia or this is gallstones. That I don't know that that's going to happen in my lifetime, or probably anybody who's thinking about going to medical school today. I see that as something that's going to end up helping in the long run. It's going to help make a radiologist day better if as soon as the images come out to you, they have been run through some sort of artificial intelligence program that says, hey, on this chest X-ray, here's a couple of spots we want you to give a second look to. Make sure you pay attention to these, and just point out things that are subtle findings in hard to look at areas that that it's there may be something that's abnormal, there may be not, but spend some time looking at this and kind of directing it. I also think there's already working on an application where when you're looking at small lung nodules on a chest CT, and we're talking 2 millimeters, 3 millimeters, much smaller than a BB, and you're comparing, did this get bigger since last year's scan? And it's so small, it's kind of hard to tell if it actually got bigger or not. But there are artificial intelligence programs that look at those, analyze them in 3 dimensions, and it'll give you a volume. I'll say, yeah, this is definitely the same, or no, this is, increased in size. Whereas your eye, may not be able to pick up such a subtle difference on something that's very small. So that's where I see computers and artificial intelligence helping me and making my job easier in the future. So yeah, in radiology, gosh, you don't, again, talking about not having film anymore, I can read images from off-site. I can read images from home if I've got the right equipment. So you
Wow.
don't necessarily need to be in the hospital as the radiologist. You don't need to be in the same state as the hospital that you're working for. So that gives you a lot of flexibility, and the hours. Gosh, they need imaging at 2 o'clock in the morning on Saturday just as much as they need it at noon on a Tuesday. So if you say, gosh, I'm really interested in, um, I love to go hiking all week and I'm going to live in Colorado, but I want to do all my radiology from Friday through Sunday night and then have the rest of the week off to do other stuff. There's a job out there where you could do that.
That's
You can kind of
amazing.
get the hours that you want, kind of work for the company that you want, the hospital that you want, from wherever you want to be. So that's kind of, I think it's a real advantage for radiology that you can't do if you're running a practice where you physically have to see patients.
Yeah.
And even that's changed too with the COVID-19. We've seen a lot of practices and a lot of hospitals now offering telemedicine and television,
Yes. Right.
where a year ago there was, no, we're not doing that. That doesn't sound like a good idea. That sounds like it would be tough. I don't know if I'd be doing the patient justice. And I think that what they found is, for a lot of routine things, it does just fine, kind of like this Zoom meeting, where, it saves time. And if it's something that can be readily diagnosed and readily treated, by talking, or maybe holding a camera up to, what you're looking at on the skin, that would be great. I don't know that you want all of your visits, for the rest of your life done over that. Sometimes you have to, put a stethoscope onto someone,
Mhm.
or do a physical exam to really get to the bottom of it. But that's been a huge advance that a year ago, you wouldn't have expected. So yeah, I would definitely encourage anybody who's thinking about medicine or thinking about radiology, you know, definitely pursue it and see how far you can take it. It takes, a little bit of, a little bit out of your comfort zone to, go do these rotations in a hospital to volunteer, or to, shadow someone, or take some classes that you might not be interested in. But that's how you're going to find out if it's something that you really want to do for the next, 30 or 40 years of your life.
Right. Well, I got to tell you, Dr. Mitchell, I can't thank you enough for talking through this today. This has
That's
been awesome. I mean, just a
good. It's been
chance
my
to,
pleasure. Yeah.
yeah, just to learn more about your profession, and most importantly, I mean, just some great advice for these future students that are considering medicine and everything else like that. So let me go ahead and I'll stop the recording here
Sure.
with you, but I wanted to thank you for that. So hang on just a minute.
Absolutely. Absolutely. Thanks, Dan.